Dear colleagues, it's a pleasure to be again with you this year and on the summer school, international summer school in Rijeka. And this today topic is class 2 malocclusion, but myofunctional approach in treatment. Many of you не иде. Kako ću sad?
Vrliš na ovaj scroll.
I samo da scroll. Dobro. For those who don't know me, I want to introduce myself. My name is Gabriela Turcheva-Chuchkova. I came from Skopje, from Macedonia. In nowadays, no Macedonia, Macedonia. And I work as a professor at the Faculty of Dental Medicine, Department of Orthodontics, Universities in Cyril and Methodius. This is the main building of the faculty on the photograph. And also as orthodontist at the clinic, University Dental Clinical Center, St. Panteleimon. As I said, I was first time in Rijeka last year, also as a lecturer at the International Summer School. Also, I'm a president of Macedonian Orthodontic Society. Macedonian Orthodontic Society is a very active society, established in 2005, but from that time we organized 3 congresses and many symposiums courses. We are also so active as a member in World Federation of Orthodontics and European Federation of Orthodontics, and in Balkan Association we are founded member of the Balkan Association of Orthodontic Specialists. For a couple of days, 10 days, 2 weeks, we will have a congress in Ohrid, our national 4th congress, and also the 3rd congress of Balkan Association. So, in the name of this introduction of our society, as a president and organizer, a president of the scientific board, I invite you all to participate at our congress. This is some pictures from last year, as I want to express my gratitude to Professor Spal, who invited me for the second time to be with you and do a lecture. As he used to say, how he came in Macedonia through Norway. First time when he was in Oslo and met Professor Vanteska, who was lecturing in Monday at the opening of this summer school. He learned a lot about our association, came to with oral presentation at our 3rd Congress in Ohrid 2016. And after that, we have many occasions invite him to lecture on some symposium and courses, also 2017 in Koira, and also we met each other in Zagreb, and I want to express my biggest sympathy not only to Professor Spal, but to whole staff at the Department of Orthodontics, Vishnia, Martina, etc., for their hospitality, and everyone who came in Rijeka for the first time. I'm sure you will come next year year and next year and continue to coming again and again.
At least for some creating or
We start now with class 2 malocclusion. Today we have some cases with class 2 malocclusion. I want to start with, because what is class 2 malocclusion? It's classified in anteroposterior, in sagittal dimension. And classification came from the father of orthodontics, Edward Engel, who classified in sagittal position according to position of the molars, the first permanent molars. But Edward Engel asked himself and asked other orthodontists, what is malocclusion exactly? Is it misalignment, simple misalignment of teeth, incorrect position of the teeth between the two jaws, or combination of sagittal, transversal, and vertical maxillomandibular discrepancies? And the severity of the malocclusion depends on variable and numbers of elements. Dentoalveolar, skeletal discrepancies, but also soft tissue discrepancies, and combination between them. So, if we start from the point class 2, how we define class 2 malocclusion in dentoalveolar processes. We call it, I don't know for you, but at our faculty we teach our students that class 2 malocclusion it's similar with distal occlusion. What is distal occlusion? Distal occlusal relationship of the posterior teeth of the molar and canine. You know where is the long axis, but on this slide you can see we can have half premolar dimension of class 2, and we call it half class 2, and whole class 2 if it's whole dimension of the premolar, distal position of the molars and canines. Also, we have class 2 malocclusion classified by British classification. You know, the British classification classified according to position of the incisors. And class 2, they have class 2 incisor relationship, not molar relationship, but incisor relationship. Depending on the position of the incisors in maxilla and mandibular, we divide it into divisions. Class 2 division 1 and class 2 division 2. But this is dental-alveolar relationship. Dental-alveolar relationship. What about skeletal relationship? These two types of class 2, it's completely different. I think beside the dental relationship, they don't have anything in common. Because in class 2 division 1, you can have patient with high or a low angle. It have transversal discrepancies and vertical discrepancies, meaning deep or open height. But in class 2 division 2, there's always deep bite. Always deep bite. What about the maxillary dental arch? In class 2 division 1, it's almost, in every case, narrow and compressed. But in class 2 division 2, it's wide. And the apical base is wider. But in class 2 division 1, it's always small apical base. In class 2 division 1, Maybe class 2 is based on a sagittal class 2. Maybe it's basically inherited. But always combined with the soft tissue dysfunction. In class 2, division 2, we don't have dysfunction of the muscles. I will focus on class 2 division 1, not in class 2 division 2, because it is maybe this lecture will be last 3 hours. I have focused on both division. Class 2 division 1 malocclusion, the etiology maybe hereditary, based on genetics, always on dysfunction, compromised by dysfunction, mouth breathing, reverse swallowing, always lip incompetence that you never see in class 2 division 2, lip incompetence. The lip are competent in class 2 division 2. And bad oral habit, who worsen the malocclusion, tongue thrusting, sucking habits, and etc. In general, when you look how the patient look extra oral view and intraoral view. In general, the patient has convex profile. The lips are apart, so it means incompetent lip. Upper lip is protruded, prominent, and short, and the lower lip lie under the upper incisors lie over the lower lip. Almost in most of the cases, they are shorter lower third of the face and deeper sulcus mentolabialis. When we look inside, from the intraoral view, the patient always has narrow maxilla, maxillary dental arch. It's always longer because of the protrusion of the incisors, many times in V-shaped. Apical base is small. They have maxillary incisors in pro-inclined position. Overjet is very increased, sometimes 12 to 40 millimeters, depends on the severity of the malocclusion. Mandibular dental arch is in retroposition, but it might be in normal shape, in normal length, but sometimes it's shortened and compressed, especially in the front, and the mandibular incisors are crowded. That is the global opinion about class 2 division 1, extra and intraoral view. Class 2 division 1 is very big aesthetic problems. The patients have aesthetic problems with class 2 division 1, but it depends of severity of the malocclusion, and I don't want to repeat. Dental velar, skeletal discrepancies, and combination, but also soft tissue dysfunction. And you can see class 2 division 1 in different mild or severe class 2 division 1. Different type of severity of class 2 division 1 on these photos. Basically, class 2 division 1 is associated with skeletal pattern, class 2 skeletal pattern, commonly combined with retrogradic mandibula, but also associated with vertical skeletal pattern. The proclination of upper incisors and retroinclination of the lower incisors result in increased overjet. And in the resting position, soft tissue and their functional activity also play a role in the severity of the malocclusion. The influence of the soft tissue is maintained by the skeletal pattern. We have dentoalveolar or skeletal class 2 division 1, and as you can see on these photos, there's a big difference between dentoalveolar or skeletal pattern. In the first case, only the processus alveolaris of the mandibula is a retrogradic position, but basically mandibula and maxilla are in the normal position with the cranial base. But in the skeletal, you have patients with the pronounced maxillary, not only dental alveolar processes, but the whole maxilla is anterior positioned according to cranial base. We always have to do the röntgencephalometrics to see where is the problem. When we examine the patient, you have to check the history, to check the dental casts, but also functional examination and extra and intraoral. And to see the whole picture, you must have the röntgencephalometrics, because there are possibilities of the combination of discrepancies is 4, 5, you can see. In case of class 2 division 1, maybe maxillary prognatism, but combined with normognatism of mandibula. Sometimes maxilla is in normal position combined with the mandibular retrognatism. There's patient with bimaxillar retrognatism, but domination of the mandibular retrognatism, and opposite maxillar mandibular prognatism with domination of the maxillary prognatism, and maxillary prognatism with mandibular retrognatism, which is the most severe cases. And we look now how maxillary prognatism and mandibular retrusion look like on a patient face. Protruded maxillary alveolus, characteristic of the protruded maxillar alveolus, only the maxillary alveolus. The anterior segment of the processus maxillaris is labially inclined, but the maxilla is with normal size, normal length. When I speak about size, I think about the length of the maxilla. The upper lip is protruded, excessively inclined with the, regard to Frankfurt plane, but less inclined in relation to occlusal plane. And in some malocclusion, we can see the diastema between the central incisors. The patient with maxillary prognatism, basal or skeletal prognatism, there are characteristic. Subnasal cutaneous region is distorted in a forward direction. The profile is always convex in any case of these 4 types. The maxillary molars and canines are in a mesial position. In this case, the maxilla is large. the length of maxilla is increased. The pointon is advanced. The distance from the distal position of the maxillary molar is increased compared to the vertical pterygoid plane, and the maxillary alveolar process is advanced. When we have a retrognatic mandibula as a specific cases in class 2 division 1, what is the characteristic of this type of malocclusion? Always the profile is convex, but menton, cutaneous menton, and the body menton is positioned distally. The mandibula may be with normal size in normal length, but in the most of the cases it's reduced in a reduction of the body length of the mandible, with or without a reduction of size of the rams, and posterior displacement of the tongue. The mandibular molars are in a distal position. And the last type, retruded mandibular alveolus. Characteristic are entire mandibular arch in distal position from the base of the mandibula. Only alveolar arch is distally position from the base of the mandibula. Menton is in the correct position, not as previous case. The lower lip is retruded and the mandibular incisors are lingually inclined. According to McNamara, only 10% of the cases with class 2 division 1 exhibit maxillary protrusion. Most of the cases have a maxilla in their normal position, in a neutral position, and 25%, even 25%, in a retruded position, accompanied with retruded position of the mandible. So now we start to think how we do our treatment plan according to these 4 types of malocclusion. Because clinical manifestation of class 2 division 1 is always accompanied with transversal and vertical discrepancies. And treatment strategies could be etiologic, which means correct malfunctions and harmful habits, orthopedic, functional, orthodontic, or combination. Treatment should be designed to be with harmony with facial type and the mode of growth. And always first resolve the transversal problem. By treating the transversal problem, first, you can allow the movement, mesially movement of the mandible, and eliminate any mandibular blockage. And you know what you have to do. Evaluate the cases. Anamnestic, extra, intraoral examination, functional examination, dental cast analysis, and of course, rentgen diagnostic. Treatment strategies depend on age. When we start with the treatment of class 2 division 1, is it primary, mixed, or permanent dentition, and that will be the key what kind of appliance we will use. Of course, severity of malocclusion is very important in that decision, and type, craniofacial type. Is it normal, vertical, or horizontal groove pattern? You have many options, variety of appliance to use, but you have to choose in proper age of the patient when you start treatment. Of course, in an early mixed dentition, you can use removable appliance with transversal screw, because you have to resolve first the transversal bone to eliminate any blockage and allow mandibular to grow up and move forward in the mesial direction with hot splay. You can use always functional appliance. There's a lot of questions, discussions early in the morning about functional appliance, how they acting and their results and effects. But of course, first we have to resolve the transversal dimension. You can use pioneer, twin block, Frankel type 2. You can even combine with a traction, with a headgear traction, etc. It depends when you choose to treat the patient with the functional appliance, combined with the traction. You must be aware what type of pattern has that patient. Is it brachyfacial, mesiofacial, or dolichofacial type? Because in brachyfacial, in mesofacial type, you can use earlier the traction. But for dolichofacial type, you have to wait for the completion of the permanent dentition. And type of traction should be low cervical in brachyfacial, combined occipito-cervical in mesofacial type, and in dolichofacial type, occipital or oblique traction. And as we heard yesterday on the lecture of Professor Neda Stefanovic, she spoke about rapid palatal expansion. She told us that she started very early with early mixed dentition. She put bands on the molars, primary molars, and expand very early. You can use, we don't use so early. At our clinic, we don't use Hyrax or bonded rapid maxillary expander, has expander so early. We wait until permanent premolars erupt in the mouth, and then we start. But I have to tell you that in case class 3, we start much earlier, combine the rapid palatal expansion with the mass, with the belly mass. And normally, you, in some cases, can make progress with distalization of molars. What do you think? In which case you may apply headgear appliance for distalization of molars? In which of that 4 types? And why did you distalize the molar permanently? Because with headgear, you don't distalize only the molar. you do something else with maxilla. You distalize the whole maxilla. And if it is in anterior position, it is okay. But according to McNamara, only 10% of the whole cases are cases for a headgear. Not every case is case for a headgear. That's not only my opinion, I find in the literature, but that don't must be your opinion. I want to hear your opinion about headgear and distalization of the maxilla.
I don't think that you could actually move it backwards, but maybe prevent in growth.
The headgear.
Yes.
To stay still.
Yeah,
To-
yeah, kind of.
Okay. There's another appliance, herbs, and some modification of herbs appliance. We don't use at our clinic herbs appliance. But also it's a very positive effect from the mandibular advancement device, especially in mouth breathers and post-spation. No, post-spation. Sleep apnea patient, yes. Okay. Treatment strategies will be designed to restrain the horizontal component of the maxillary growth, eliminate any obstacles to mandibular movement, modify neuromuscular behavior, and discourage harmful habits, and to help to retrain the tongue and the guide the eruption of permanent teeth. We can use the time of growth to modification of growth, of course, with functional appliance and combination with fixed appliance, intermaxillary traction, mini screw anchorage, etc. After that, when the growth is completed, in the case of mild type of malocclusion, you can do orthodontic camouflage, and of course, add on the list orthodontic surgery in most severe cases. And before I start with talking about myofunctional approach in class 2 division 1 treatment, I want to go back at growth and development. The basic principles and characteristic of the patient facial development is down and forward. And the individual facial growth and development is closely related to functional activity of very much different components of the head and neck, according to functional theory, most functional theory. And the growth will achieve the maximum potential if you start to treat the patient earlier. If the tongue is in the correct position, if the patient breathes through their nose, and there will be more space for the anterior and the posterior teeth to erupt. And at the age of 5, you can see this occlusion. Excellent. With physiologic diastemas, enough space for every permanent teeth and enough wider and length of the dental arch. And in this lecture, I will focus on the soft tissue dysfunction. Because soft tissue dysfunction as a driving force behind malocclusion is not only my opinion. It dates long before I start to learn orthodontics and practice orthodontics. Even from Engel and after him, especially Frankel, soft tissue dysfunction influences not only the growth, the bone growth, but also your decision treatment, your result of the result of your treatment, and the stability at the end of the treatment, and should be overcome to allow normal growth. And most important thing, we should look when the patient came in our practice, we should look at the position of the lips, the position of the tongue, and combination of these two. Having in mind how powerful is the tongue and its muscles, because with his activation through whole day in swallowing, he raised force of 500 grams, 500 grams, and it's enough to expand the dental arches. But if it's in the correct position, with the tip on the vault of the maxilla, behind the palatal surface of the maxillary incisors. Oral respiration, breathing type. It's also very important to look how the patient breathes. And if it is have some problems in breathing, usually the position of the mandibula is retro-inclined. That patients have exceed vertical dimensions, increase lower facial height. The tongue assumes a lower position than in the oral cavity, and the mandibula may not contract the maxilla during swallowing. And also the maxilla is always compressed and narrow. Myofunctional orthodontics, it's a new approach to the diagnosis and treatment, and tends to improve the muscle function and reduce the soft tissue function. We should appropriately identify soft tissue dysfunction to provide better performing the treatment. Frankel is one of the greatest orthodontics in the field of functional therapy, and create a completely new era in the functional therapy. Basically on the three basic principles: application and elimination of pressure, and application of traction. When you think about application and elimination of pressure, you must be aware of where you should applicate and where you should eliminate pressure. But he designed very good appliance with the buccal shields and lip bumpers. How I can describe these bumpers? to do the both eliminate and applicate the pressure. And when we look at the patient in our office, in our practice, the position of the tongue, it should be located on the roof of the mouth, just behind the outer surface of the incisors. Breathing mode is very important. Normally, it should be through the nose, not through the mouth, and swallowing pattern is also important. The patient should swallow without any activity of musculus mentalis. And the type of appliances that we use in primary dentition, in early mixed dentition, we start with infant trainer in primary dentition. This infant trainer has tooth channels and labial balls to guide the teeth and erupt in a proper manner. Also, tongue guard to prevent tongue thrusting, and lip bumpers to discourage overactive lip muscles. And because we apply in little children, 4 or 5 years old, they have strep texture. It's don't have any activity in treatment of malocclusion, but to not to lose the appliance, to hold the appliance on the dead strep texture. The trainer, infant trainer, is designed to train the jaw's muscles to correct the swallowing pattern, the breathing pattern, and correct the position of the tongue. And I will show you only one case of class 2 division 1. In this patient, I'm very sorry for the dental cast, because usually our technician, our colleagues in dental laboratory do not want to do complete the proper dental cast, and when we ask them to proper modulate the dental cast, they usually broke some teeth and fulfill with wax. So I don't know, do you have problem to see the overjet and the position of the maxillary mandibular incisors? Because that is the most important to see. They were trainer, infant trainer, every day per night, and only 1, sometimes 2 hours per day. The trainer system has 2 or 3 steps, and it's made from different material. The first step is made from the silicone, and another step we move with a harder type of trainer, which made from polyurethane. You know what is the material polyurethane. So the first step with the trainer, the patient learned 4 to 6 months. After that, we start with the second step, the harder type of the trainer. And the whole treatment lasts maybe a year. And the results is after 1 year of treatment, this child. Myobrace is a type of trainer. Myobrace is a different type for early permanent dentition, for permanent dentition, and teenage period, and for adults. But I show you only the early mixed dentition type. It's a non-invasive device and have big therapeutic effects in a short time period and stable results. They also have tooth channels, tongue guard, and lip bumpers. I don't want to repeat myself. If you want to ask something about this type of appliance, you can ask a question. No? Everything is clear. Okay. And now some cases. What kind of class 2? Division 1, do you think is this? With very narrowed, compressed maxillary dental arch, even cross bite from the left side, scissor bite from the left side, and overjet is almost 8-9 millimeters. We apply this type of appliance in this child, and you can see immediately when they put the appliance in the mouth, a change of the profile in extremely forward position of the lower lip, because the children move immediately mandibular forward. This appliance is basically constructed according to Frankel principles. That's why I speak about Frankel, because in this appliance the tooth guard focus on the eruption of the teeth, but eliminate the pressure of the buccal muscles, and the lip bumper eliminate the pressure of stimulate the lower lip, and what is the most important, we teach patient to close the mouth and lip together. Seal the lip and stay in position to keep. Yes. It's very difficult in the first 1 week, maybe 10 days, but after 2 weeks they are ready to adapt on the appliance. And I when my colleagues ask me how they adapt on the appliance, I say very easy, because 10 days or 2 weeks, it's not a long period to adapt.
Willing parents.
Parents.
Willing parents.
And now I will show you some treated cases and finished cases. This is Matej, who has class 2, division 1, with protrusion of the maxillary incisor. But you can see the mandibular incisors are not in retroinclined position, but also you can see the bad habit, tongue thrusting. and it's a good patient for this type of appliance. After the first and second step of the treatment with MyoBrace, at the end of the treatment and 3 years after the treatment. Only MyoBrace, we don't apply any other type of treatment with any other type of appliance, orthodontic appliance, only with MyoBrace, and correct the bad habit. This guy, I'm sorry that I don't have experience in technical experience, and on my laptop I cannot yesterday put from the telephone, from the cell telephone, the photo, the last photo, to see the result in Alec. Alec has cerebral paralysis, but he's a very brave guy. He trained his muscles, he trained football, and he started with this appliance, adapt on appliance for less than a week. And we treat them with 3 steps. Year and a half, and now as you can see in the mandibular arch, they are crowding, mild crowding, but there are the mandibular incisors are crowding. And in the second step, you can see there are no crowding at all in the mandibular dental arch, and the open bite are closing, and now at the end of the treatment they are completely resolved. The open bite is completely resolved. Another, this is not a class 2 case, it's a class 1, but with a protrusion, because if you can see in the molar region and the canine, there's also the axis of the tip of pupomesial tip of the maxillary molar is in the correct position in first class malocclusion. But Yvonne has a tongue thrusting and protrusion of the incisors, so we used this type of MyoBrace. And Joanna has class 2 division 1 malocclusion, but also tongue thrusting with years. And her parents are desperate. They don't have any other options to teach her not to put her tongue in the mouth, and we start with MyoBrace, and every 3 steps at the end of the treatment you can see the results in the occlusion of the patient in the mouth, but also her profile is improved, almost from convex to flat profile. And Tamara, as the last patient I show you, but for me is the first patient, and in that time when I start in 2008, we start with MyoBrace. In that time they call them T trainer for kids, T4K. And have only 2 types, silicone and polyurethane, only 2 types. And because we have at our clinic a very small number of appliances because we just begin with treatment with myobrace. And I don't have blue type, the first type, which is silicone and much easier to adapt on that appliance. So, when I see the patient, I decide to start with step 2, and this is the result at the end of the treatment. It's very hot. Some of you, as I look at you, sleepy. I speak slowly. My English is not fluent. I'm sorry. And to repeat some. At the end, the results and conclusions. What is the meaning of treatment with myobrace? Optimal jaw alignment, correction or reduction in maxillary incisor protrusion, overjet reduction, and improved facial profile. The final outcome of the treatment is not to eliminate the need for orthodontic treatment. The role of the pre-orthodontic treatment is to attempt to eliminate the myofunctional habits that cause malocclusion and interrupt normal craniofacial growth pattern. An added bonus of treatment is improvement of the profile. And at the end, I want you all to invite again at our third BAUS Congress and fourth Congress in Ohrid for 2 weeks.
It's almost like in Rijeka, so I can barely see Cook Island.
You don't see the first slides. And if you want to see, I will back on the first slide. When I told that I came second time, and probably they all will come in Rijeka because of your hospitality.
Yeah.
You will remember some.
Oh, yeah. How many years ago was that?
2016.
3, 1, 2, 3.
3. Yeah.
First time in Ohrid 2016.
Each year, so each year, at least once.
At least once.
At least.
Prvi slajd ste slikali, nemam.
Prvi slajd Martina je slikala, a ja sam snimila sve.
Da, ne treba. Da si mogu.
Yeah.
Okay.
Shall we take a picture together? Are there any questions?
If there are no questions, they
If you have
learn
some
everything
questions,
or
maybe not rising now, but tomorrow you can approach Professor Gabi and ask her and discuss maybe some of your cases that you have. Because Gabi will be with us for 2 more days.
Until Friday.
For 2 more days. There will be time to discuss with her your cases.
Dobro. Safety ring. Samo tako. Ne. Aha, izlaziš gore pa... a onda trebam ja